We're going to talk about transcutaneous pacing, in this case using the LifePak 12 monitor. So let's turn on our monitor and see what kind of underlying rhythm we have here. So I have the limb leads on, and I'm looking at a bradycardic rhythm in the high 20s. If we look at our printed strip, we can see nice, regular RR intervals, or the QRSs, very regular. But you can see the P waves are completely disassociated from the QRSs. There's no rhyme or reason to it, so we could safely call that a third-degree block. Not a very healthy rhythm, not something we want to ignore. So in this particular case, we would assess the patient and see if there's hemodynamic instability, meaning if he was hypotensive, if he was unconscious, of course, if he were having cardiac chest pain, or if he were in pulmonary edema. Any of those things that could be rate related, caused by a slow heart rate, we would have to deal with. So in this case, let's say he's hypotensive and we're going to go about externally pacing this fellow. We put the big pads on him, the multifunction pads. You can pace anterior lateral, but most textbooks and most manuals will recommend pacing in the anterior posterior position. So we have our pads placed. The next thing we need to do is tell the patient what he's going to feel. So if we describe that he's going to feel some energy passing through his chest, and it's going to feel like a thudding or a tapping, maybe even some twitching or stinging sensation around the pads, that's all normal. It will feel like a thudding. It's not comfortable. It's not out and out painful, but it is uncomfortable. If he knows what to expect before we actually do the therapy, he's much better or much more likely to tolerate it well. So, next thing we want to do is turn on our pacer. Of course, it's going to ask me, do you want to enter manual mode? And yes, I do. And it has a default setting of 80 paces per minute. And I'm going to say that's just fine. Now, I'm going to want to turn up my current. So over here, I'm going to turn up the up arrow on the current, which is currently at 0. And you notice on the LP12, it's going to mark the QRSs with that little triangle. I don't know if you'll be able to see it from where you are, but each QRS has a little triangle to mark the inherent or the underlying rhythm. Now I can turn up the current two ways. I can press this arrow over here, which will up it by 10 milliamps each time, or I can just use the selector knob and dial up the energy 5 milliamps at a time. So I'm looking at these pacer spikes, these little narrow things, and I'm noticing there's nothing coming after them. So I'm turning up the energy until I get capture. And I've just started to get capture there at 95 milliamps. So you can see capture should look like a wide, complex QRS immediately after each pacer spike. Sometimes I'm getting them, sometimes I'm not. That means I don't have enough energy, so I'm going to give them a little more milliamps until I'm consistently getting capture. Right now I'm still getting intermittent capture, so I'm going to give them a little bit more. The average on a LifePak 12 is to capture somewhere around 95 to say 105 milliamps. Occasionally you might have to turn it up higher. Like this guy I've got going up to 150 milliamps before I've got consistent capture. So there's going to be some discomfort with that. Now I need to make sure that not only do I have electrical capture, but I got to make sure I have mechanical capture. So I want to take some blood pressures, I want to feel peripheral pulses, and to do that, I'm going to use the right arm wherever possible, because the left side of his body is going to have more twitching and muscle movement because of the pacing, because the pads sit off to the left side. So when you can use the right arm for blood pressures, that's definitely the way to go. Now some other tips for obtaining assurance of mechanical capture. One, we said the peripheral pulses. Two, we said blood pressures. Another way you can do is put the sat monitor on and set up the SpO2 waveform down here. Now if I'm getting circulation right to this gentleman's fingertips, then I should see SpO2 waveform at 80 beats per minute, not at the 20 something that he was going at previous to therapy. So I'm going to look for good blood pressure, peripheral pulses, SpO2 waveforms, there's a number of ways that you can check for mechanical capture as well. Just improvement of patient color, levels of awareness, decrease of chest pain. All those things would tell me that I'm getting good mechanical capture. At this point I could turn down the rate. So if I go back over to rate and I go, let's see, he's doing very well at 80. Let's take him down to 70 for a bit and see if he still maintains good peripheral pulses, good blood pressures. And if he does that, I can take him down to 60 and see how he does there. If he still has good blood pressure, good output at 60, all the better, because we know the faster that we make the heart go when someone's having a cardiac event, the more that we increase their max VO2 demands. And so if we can have them down at 60, all the better for this guy not to work so hard, because we know that high degree blocks, like a third degree block, are most commonly caused by an acute myocardial infarction. So we really don't want this guy to work harder than he has to. So there he is at his rate of 60. I check his blood pressure again, make sure it's good, and then I prepare for transport. Of course, I could consider, if he's really uncomfortable with the sensation of the pacing, I could consider some sedation at this point, which has benefits and risks to it, and that's a bit of an analysis that you would have to do and judge whether that would be a good thing for each patient. The upside of sedation being that it would, it's a compassionate thing to do, takes away some of the discomfort. The downside is that it has side effects like possibly hypotension, respiratory suppression, and obtundation. So if if I suddenly lost capture for whatever reason, now I've got a sedated patient, now he's even worse off than he was in the first place. So that's a cost, benefit analysis that you need to do individually for each patient case. When you get to the hospital, one other thing we need to mention is typically when you get to the hospital, the emerge physician or the nurses are going to say, what are you doing? Oh, I'm externally pacing this patient. Well, take that thing off. Because they're not comfortable with your therapy, they're not sure it's indicated. They'll say, take that thing off, and you'll go, oh, I really don't know if I should do that. What you can do is you can hit the pause button here. See over here with the pacer? You can hit this pause button and say, you know what, before I take the pacing off, why don't I just show you the underlying rhythm? So when I hit the pause button, it stops pacing for a bit, and then shows the emerge physician, see, he's in a third degree block, and he had like no blood pressure. At that point, the doc might say, well, maybe you should leave it on, and you go, okay, I'll leave it on. When you release the pause button, it should start pacing again. And there it goes there, started pacing again at 60 beats a minute. So as a good patient advocate, you really should make sure that the emerge is well prepared and well able to handle that symptomatic bradycardia before you take your monitor off.